Good morning, everyone. Today I am presenting slide discussion for topic Sebaceoma. First is introduction. Sebaciomas are benign sebaceous neoplasms composed of baseloid cells and mature sebocytes. They may be associated with Muir-Torre syndrome, but can also be an isolated or sporadic tumor. Epidemiology. The female to male ratio is 4 is to 1, and it can occur amongst a wide age range, but the majority of patients are in the 6th to ninth decades. As we can see here, under the latest WHO classification for skin tumors, that is the 2018 WHO classification for skin tumors, we can see that sebaceoma has been classified under tumors with sebaceous differentiation. We can also see that under the headings of tumors with sebaceous differentiation, there is sebaceous adenoma and sebaceous carcinoma. We'll learn how to differentiate sebaceoma from them in my upcoming slides. So, one more thing we need to discuss before talking about the clinical and microscopic picture is terminology. When we say sebaceoma as a term, sebaceoma is used for tumors with more than 50% of baseloid cells being seen in the microscopic picture, whereas the term sebaceous adenoma is used for tumors where the baseloid component is less than 50%. uh, Another term that is used but it's a confounding factor and therefore is being discontinued is sebaceous epithelioma. As sebaceous epithelioma as a term, it is confusing and is could refer to a low grade form of sebaceous carcinoma, a basal cell carcinoma with sebaceous differentiation, or sebaceous proliferations of uncertain potential, and therefore it is considered not a useful term, and therefore this term is no longer used. Sites primarily occurs on the face and scalp. Occurrence on non-head and neck regions should prompt consideration of Muir-Torre syndrome. The Muir-Torre syndrome is considered a phenotypic variant of hereditary non-polyposis colorectal carcinoma syndrome and is caused by germline mutations in one allele of the DNA mismatch repair genes, most commonly MLH1, MSH2, MSH6, and PMS2. Epidemiology, as already discussed before, the female to male ratio is 4 to 1 and it can occur in the 6 to 9 decades. So now we'll begin with the gross and clinical picture. The basic clinical picture is that of yellow to orange or flesh colored papules, or they can be a nodule also, based on whether they are less than 5 millimeter or more than 5 millimeter in elevation. Microscopic features. The salient microscopic features are it will be a dermal nodule with variable epidermal involvement, and it will consist of baseloid cells and mature sebocytes. And greater than 50% of the tumor will be made up of baseloid cells, and therefore it will be a sebaceoma and not sebaceous adenoma. Variants of sebaceoma have been described with carcinoid like, reticulated like, cribriform, rippled, or Verroque body like features. Now we'll look at some of the photomicrographs. As seen here, sebaceoma consists of variably sized lobules scattered in the dermis, often with the involvement of the overlying epidermis. The lobules lack an organized architecture and are composed of a random mixture of abundant baseloid cells and small numbers of mature sebocytes. The case shown here consists almost exclusively of baseloid cells and only rare mature sebocytes. As we can see in this picture here also, the baseloid cells lack cytologic atypia, and also we can see the sebocytes here. The mitotic activity is low, and randomly scattered sebaceous cells will be seen, and they will have abundant pale staining foamy cytoplasm and small hyperchromatic nuclei. Duct formation and cystic change may also be seen, and rare cases may show reticular cribriform or dippled patterns and nuclear palisading resembling Verroque bodies. So let us now see a comparison. Here on the left we can see a normal pattern of sebaceoma, and on the right we are seeing rippled pattern of sebaceoma. In both cases we are seeing higher percentage of baseloid cells and only few scattered sebocytes. Lastly, we'll discuss the differential diagnosis. First is obviously sebaceous adenoma. In the picture itself, we can make out the abundance of sebocytes here and here everywhere. The amount of sebaceous glands are much more than 50%. Therefore, sebaceous adenoma will have lobules which try to recapitulate the normal architecture of mature sebaceous glands, and they show basilar germinative cells in the periphery only and pale staining mature sebaceous in the center. Unlike sebaceous adenoma, the lobules in Sebaceoma they lack organization and are composed of a predominant population of basilar cells that are haphazardly admixed with a small number of mature sebaceous. Sebaceous carcinoma. Most sebaceous carcinomas have a significant amount of nuclear atypia, prominent nucleoli, increased mitotic activity, and infiltrating margins, all of which are going against sebaceous adenoma and sebaceoma. Lastly, basal cell carcinoma with sebaceous differentiation. Sebaceous differentiation is sometimes an incidental finding in a basal cell carcinoma. The presence of peripheral palisading, cleft formation, and cytologic features are usually sufficient in arriving at the correct diagnosis. But still, in challenging cases, immunostains can be helpful. EMA and D240 are positive in sebaciomas, whereas BER EP4 is positive in basal cell carcinoma. Thank you.